Okay, welcome. I have two great talks to follow that have set up immunotherapy in the clinic very nicely, and it's great to see all of you here, some patients of mine even. What I wanted to cover are really putting kind of a patient perspective on some of these immunotherapies. So what would you go through if you decided to get a CAR T-cell or a bispecific antibody? What are some common side effects? You heard about that the immune system has an inflammatory and then a regulatory component. So some of the side effects are related to that inflammatory component of the immune system. So we'll talk about the toxicities of these T-cell directed therapies for myeloma. And I'm going to focus on BCMA targeted therapies. You've heard there's others out there, but I think this is kind of the prototype, and the toxicities across therapies, the activity, I think will be similar. So first, let's put this in context of myeloma therapy. A number of you have gone through treatment for your myeloma. You know that treatment typically is in phases. There's an induction, there's a consolidation, there's a maintenance or low-dose continuous treatment phase of myeloma. If you're a stem cell transplant candidate, you had high-dose chemotherapy as part of the consolidation for your myeloma in that initial induction step. And I can tell you that immunotherapies are used all throughout these steps. And the immunotherapies I'll talk about, the bispecifics, the CAR T-cell therapies, currently are approved for that later line when you relapse or you become refractory to treatments, but they're being studied and moving earlier in the treatment. One of the common immunotherapies that a lot of people have been exposed to is daratumumab, which targets CD38 on the surface, and that's from induction on through maintenance now in treatment for myeloma. Our goal with any of these treatments is to reduce the tumor burden, to get you to the lowest detectable or undetectable level of myeloma, and that's how some of these studies of CAR T cells and bispecific antibodies are gauged, is by the response rate. So let's talk about immunotherapies against BCMA. BCMA is a B cell maturation antigen, so B cells mature, they become plasma cells. It's expressed highly on plasma cells. There are three main that you may have opportunities to be treated with: CAR T cells, shown in the top, bispecific T cell engagers, which brings the T cell in contact with the myeloma, and bispecific antibodies or antibody drug conjugates. Antibody drug conjugates again have a payload of a drug that's brought in contact with the myeloma. And all these are targeting the same marker on the myeloma. They're targeting BCMA. So there's a lot of choices out there for how do you target that marker on the myeloma. And we can tell you now, we don't know which one of these is the best, and each of these may have applications for each of you individually, just based on your disease, your other comorbidities, or your other problems that you're dealing with. These are a long list of all the drugs in development to target BCMA, and only a few of them are approved. Belantamab is one that's an antibody drug conjugate. There is close to being approval for bispecific T-cell engaging antibodies, and we have one CAR T-cell that's approved. The rest are in clinical trials. So as a myeloma patient, if you can't get access to commercially available CAR or commercially available bispecific, your best option is to participate in clinical research studies for these promising therapies. So if you are going to undergo CAR T-cell treatment for your myeloma, what might you expect? There's a number of steps that I'll go over in the following slides. Number one is your myeloma, in order to undergo CAR T-cell, has to have some degree of control. It can't be growing out of control. You also have to have enough cells to generate the CAR T-cells from. I'm going to talk about each of these steps to generate a CAR T-cell and what you might undergo if you undergo a CAR T-cell therapy. So number one, your oncologist is going to plan. They want to control the myeloma. And how you control the myeloma is dependent on your disease, what treatments you've had before, but we want treatments that aren't going to decrease your number of T cells, because those are the cells we want to get from you. You'll have blood tests. You have pre-testing, bone marrow biopsy, x-rays, making sure that your heart and lung function is good, making sure that you can get through some of the toxicities associated with these treatments. You heard earlier about pheresis. We have to collect the cells that we use for CAR T cells from you, from your blood, and that's through a similar procedure. If you've undergone stem cell transplant, you know the pheresis procedure. It's a catheter that's placed to remove your stem cells in stem cell transplant, but we use the same procedure to remove your T cells, which are in your blood circulating in high numbers that we can remove just from your peripheral blood through the same type of machine that removes your stem cells. First, we have to collect the T cells. T cells are collected in the instance of CAR T therapy without any growth factor. So you don't have to undergo the Neupogen, you don't have to undergo the side effects of G-CSF. You do have to have IV access to be able to collect those cells. This whole procedure of collection is typically 2 to 4 hours. So it takes less time to collect T cells than it does stem cells. And most of the time you're collecting enough T cells in the first time that you're in the chair collecting the T cells for CAR T. But then after the T cell collection, it takes time to generate that chimeric T cell. That has to be sent off to a lab. That can take 4 to 6 weeks. That T cell modification, when that's happening, the goal for you is to have control of your myeloma so that at the end, when the T cells are done and they're delivered back to the center, that you're ready to receive them, that your myeloma is not growing out of control, that you haven't had any complications with infections or other problems that may arise. That T cell modification, again, takes 3 to 5 weeks. Prior to getting the T cells back, so now they've generated your T cells in the lab. The T cells are frozen, just like your stem cell transplant cells are frozen. They're frozen. They can remain frozen for weeks, months, longer. They're still going to be good. So the next step to get you ready to receive those T cells is to reduce your immune cell numbers, have some effect on the myeloma, and that's called lympho-depleting chemotherapy. Unlike in an auto transplant, we don't use a chemotherapy called melphalan. We use a combination of immunosuppressive therapy called fludarabine and another one called cytokine. Fludarabine is not commonly used to treat myeloma, but it's used to get you ready for these immune cell infusions. And unlike the transplant chemotherapy, fludarabine, cytokine is not associated with a lot of mouth sores. There's nausea associated with it. And it's given for 3 days instead of the typical 1 day that you might have the melphalan chemo. One of the side effects of CAR T cells is that it can cause a lot of inflammation. That inflammation can lead to fevers. They can also cause confusion and mental status changes. So part of the process of monitoring you from the time you start on treatment for the CAR T cells through the infusion and after is to monitor your mental status. We'll talk about the 2 major side effects of CAR T cell therapies, cytokine release syndrome and neurotoxicity, in the following slides. So at our center, we would start the process of lymphodepleting chemotherapy on a Wednesday, and then you would have that through Friday and then be admitted on Sunday, and the CAR Ts would be infused on Monday morning. All of our CAR T procedures are in the hospital. In particular for myeloma, the incidence of the side effects happening right after the CAR T infusion is high. So that's why we admit all of our patients to the hospital. In the future, maybe CAR Ts will be given outside the hospital. Maybe the side effects will change, but this is what we know now. The CAR T cells are thawed out just like you would thaw the stem cell transplant, infuse them into you in your hospital room, just like a transplant. That infusion takes only 5 to 30 minutes. It has the same preservative that an auto transplant would have, so a tickle in the throat, the smell of cream corn after the infusion is common, potentially some flushing with the infusion can happen. And then we monitor your mental status. I'll go over how we monitor that in the hospital. And typically after CAR T-cell infusion, patients are hospitalized for a week to 2 weeks, typically 2 weeks. So this early recovery phase, it happens primarily in the hospital for the first 2 weeks. After the infusion, you're monitored for cytokine release and neurotoxicity. And if you leave the hospital, you have to stay around the cancer center where you received the CAR T cells. And so there's a commitment to stay there at least for 30 days, maybe even up to 100 days. The follow-up is frequent, and the monitoring is a little bit more intensive than you would have after an auto transplant, primarily to monitor for neurotoxicity and the cytokine release. So this is what you can expect if you were to be admitted to the hospital for CAR T infusion, is that it's a roller coaster ride. You get a chemotherapy, lymphodepleting fluci that's associated with some nausea typically. It's typically, patients tolerate it better than the melphalan. Decreased appetite, some fatigue. Your blood counts drop after this chemotherapy, so you're at risk for infections. The fevers after this type of chemo primarily are caused by the cells that were infused, and that happens pretty soon after the infusion. Unlike in the auto transplant, you had a week of, you had some nausea, you had diarrhea, and then the fevers happened a week later when your neutrophil count was 0. Fevers after CAR T are happening within the first, usually 1 to 2 days. The neurotoxicity also tends to appear within the first week to 2. One thing that we've observed after CAR Ts, after auto transplant, everybody's counts come up. The neutrophils recover quickly by day 14. The platelets by day 30, everybody's recovered to almost normal numbers. CAR T cells can lead to prolonged cytopenia, so lower white blood count, lower platelets, potentially need for transfusions even after you leave the hospital. That recovery after the CAR T cell, if you've had a good response, visits start to stretch out. Appointments stretch out. Your physician would monitor for disease response with a bone marrow biopsy with your myeloma labs. But you're not on any maintenance therapy. You're not like an auto, you were put on Revlimid or a maintenance therapy after your auto transplant. That's not typically part of the CAR T process, but maybe in the future in clinical studies that's being investigated might be a part of it. So that's the general CAR T procedure. I want to take you through 2 cases, 2 patients that underwent one a CAR T infusion, the other a bispecific T-cell engaging antibody treatment. Both of those patients participated in a clinical trial. The first is a 57-year-old gentleman, had myeloma. He had received a stem cell transplant, but he had progression after his transplant within 2 years. So his oncologist said, the second transplant's not a good option, let's look into new therapies. BCMA-directed CAR was chosen as his potential therapy as part of a clinical trial. He had an IgG kappa myeloma. He had not high-risk cytogenetic features, but his main risk was that he progressed early after auto transplant. That leads to a higher chance that the myeloma is going to be less responsive to other therapies, and that's what made him eligible for the clinical trial. He underwent the lymphodepleting chemotherapy with fludarabine and Cytoxan. He did well with that. That was all outpatient. He had a little bit of diarrhea, admitted to the hospital again on Sunday, and then he had his CAR T-cell infusion on Monday, went just like his transplant, did fine. The next day, he started to develop rigors, which are chills, shakes, had a fever up to 39 centigrade, also had low blood pressure. So for treatment of this, he received a drug called tocilizumab, which blocks the inflammation, and he received fluids. He responded to that treatment, but he kept on having fevers. On the 3rd day, he still had fevers. He had some headaches. He had vision change, or he had photophobia, which means bright lights were hurting his eyes. Overall feeling ill. And some of the markers in his blood of inflammation called a C-reactive protein were rising. That can mark inflammation in your body after these cells are infused. But he didn't require any more of that drug called tocilizumab. At that point, his blood pressure was stable. but he had some substantial toxicity. That fever is a classic sign of cytokine release syndrome. On day 4, he kept having fevers, had nausea, vomiting, continued to have a headache, continued to have lights hurting his eyes. That marker of inflammation called C-reactive protein was up high, way elevated, and he received another dose of the tocilizumab because of the cytokine release syndrome, or CRS. Got some Tylenol to try and help with the fevers, which in this situation doesn't tend to help very long, and the fevers continue after CAR T-cell. Fever continued to day 5 after the CAR T-cell. His wife noted that he had problems with his short-term memory, was impaired. Sometimes after CAR T-cell therapies, patients can get to the point where they can't speak. They are just kind of in a daze, unresponsive. He had some inflammation in his liver, and by the 6th day, his headache was improving. He had some chills, but no more fevers. He had stable blood pressure. All of his signs of inflammation were coming down by that 6th day, and they were looking for infections with blood cultures. All that remained negative. So by the 8th day, he had been without a fever for 2 days, was thinking clearly, feeling well, and he was monitored from the 8th day for another week just to watch for further cytokine release syndrome and the neurotoxicity of CAR Ts. And he was discharged from the hospital. And when he was discharged from the hospital, he was discharged with low counts, a low neutrophil count of 1,000, platelets of 72, and a mild anemia. Those are common things after CAR T cells. But now 2 years later, after he's been treated, he's had a complete response to treatment. His myeloma is undetectable. That's one of there's an upfront toxicity cost of CAR T cells, but the responses can be high. These are the 2 BCMA CAR Ts that are, one's FDA approved, one is not. The overall response rate is around 80 to 90%, and half of people can get to, on the left chart it says MRD negative, that means measurable residual disease negative. Half of patients can get there. These are patients who've had multiple relapses of their myeloma, really aggressive disease. And the complete response rates, this patient I gave you the example of had a complete response rate. Not everybody has a complete response rate to CAR T cells. About half, 40 to 50% have a complete response rate. But the majority of patients who get this therapy have cytokine release. That's shown on the table on the right. Cytokine release happens in release syndrome, those fevers, the low blood pressure, potentially problems breathing. That happens in 90% of patients who get this therapy. And neurotoxicity, or the confusion, the problem communicating with his wife, that can happen in 20% of patients. In some CAR T cells for other cancers, you'll hear of numbers that are higher. In different CAR T cell studies for myeloma, there's a variation of how often that neurotoxicity happens. In general, the cytokine release across what are available CAR Ts are 80 to 90%. So the 2 main problems with CAR T cytokine release, that typically happens in the first 3 weeks. That's why you're hospitalized for 2 weeks if you're undergoing that procedure. The neurotoxicity, typically we're seeing it within the first 2 weeks that you're in the hospital. There are some reports of patients having it delayed after the CAR T cell therapy. And we know that in this disease, in lymphomas, that after CAR T cells, we're ramping up the immune system. We're getting this T cell attacking the cancer. That inflammation leads to cytopenias. There's some off-target toxicities affecting your cell's ability to make cells, and that's leading to low blood counts, low white count, red count platelets. And because this marker on the surface of myeloma is also on your normal immune cells, you're going to be at risk of infections more than somebody who hasn't gotten this treatment, because B cells express this B cell maturation antigen. That's one case of chimeric antigen receptor T cell therapy. An alternative BCMA targeted therapy is a bispecific T cell engager. This is a case of somebody who underwent a bispecific T cell engager. That's an antibody that targets BCMA. The other end of the antibody is grabbing onto the T cells, bringing them in contact with the myeloma. So this patient was older, 74. The other patient was in his 50s. had multiple myeloma. He was enrolled in a clinical study of a bispecific that target BCMA and CD3 called TNB-383B. He had an refractory myeloma, an IgA kappa myeloma, had undergone transplant in the past, had recently been on daratumumab and carfilzomib, but wasn't responding, and his light chains were rising. So that's why his oncologist recommended a clinical trial with this bispecific antibody. He was feeling fine, no symptoms prior to the infusion of the antibody, and presented to the hospital for this infusion, which is all given in the hospital, for monitoring of side effects, and he presented in good shape. He felt well that morning when he was ready to start the infusion, but a few hours after the infusion, he developed chills, he developed nausea, he had a fever at 103. He got confused, he was incontinent, he had more nausea. He was kind of ICU level care on the second day because of his high fevers and marginal blood pressure as a result of all the inflammation caused by the bispecific antibody. He received the same treatment that the prior patient received, tocilizumab. He received steroids. That suppresses the inflammation, blocks that inflammatory signal. And 2 hours later, after getting that treatment, he was more lucid, able to name the year or the place. He was able to recognize his wife again. So the treatments of the tocilizumab, dexamethasone, in this case and in the CAR T-cell, helped to reverse those major side effects. By day 3, he didn't remember the prior day, but he was feeling a lot better after getting the treatment for the cytokine release and the neurotoxicity that he had. He had a moderate grade of cytokine release syndrome. He had a higher grade of neurotoxicity. We'll talk about those two major side effects after this case. And he responded well to this drug, tocilizumab and dexamethasone. And by the 4th day, he was ready to go home. So he was out of the hospital less than a week after this bispecific antibody therapy. His response was MRD negative, complete response at 1 year of therapy. There are a number of bispecific antibodies that are in development. They typically are all also infused and require infusion and monitoring in the hospital. The response rates across the board of all these shown in the 5th column from the left, that's overall response rate of around 50 to 80%. Cytokine release syndrome happens with this therapy too. It happens in at least half of patients undergoing these therapies. The neurotoxicity also happens with this therapy. These bispecific antibodies target different antigens on the surface of the myeloma. The one that our patient was on was the TNB-383B, BCMA targeted, that's given every 3 weeks. Talked about it has a longer half-life, so it's not given as frequently. But the common side effects of bispecifics, just like the CAR T cells, targeting the same marker on the myeloma, a little bit different mechanism, but that inflammatory reaction, the cytokine release, which results in nausea, fatigue, fevers, inflammation in the liver, those are common also with bispecific antibodies. And the effects on the blood cells can also be seen in this therapy as well. So just by choosing a different modality, the CAR T versus the bispecific, you're not necessarily going to avoid these adverse events. And these are common, 2 common adverse events that happen after these immunotherapies are cytokine release and neurotoxicity. Let's talk about cytokine release syndrome. Cytokine release syndrome in those cases, classic finding is a fever. Common symptoms, flu-like illness, muscle aches, headaches, chills. Some of the initial studies of CAR T-cell therapy, patients got so sick they were in the ICU, they were on life support. Some patients died because of the CAR T-cell therapy. We've learned a lot from those initial cases. Those typically were cases of myeloma with heavy tumor burden, and we've developed treatments to treat cytokine release syndrome, namely tocilizumab, which blocks an inflammatory marker that's increased called IL-6, and steroids. We grade cytokine release syndrome, so if you're in the hospital and you said you had a grade 2 cytokine release syndrome, I told you one of these patients had that, that means you had fevers, you had you had a drop in the blood pressure, but you didn't require medicine to keep your blood pressure up. Now on the far right is how extreme it can get after these cells or the bispecific antibodies. You could be on life support requiring pressors to keep your blood pressure up, high fevers, on a ventilator. That's the extreme case of cytokine release. And we try to intervene, or we do intervene on patients prior to getting to that high grade of cytokine release syndrome, but that's sometimes where patients can get. It's rare, but it can happen. But we have two effective therapies for it. Tocilizumab and corticosteroids are used to manage cytokine release syndrome, and they're very effective. These graphs show after CAR T-cell infusion what happens with the fever, which is shown in the gray. Temperatures rise within that first week on all of these patients. Each of these are individual patients. The yellow line shows when they got steroids, the blue line when they received tocilizumab. And after tocilizumab, all their fevers drop along with the steroids. So it's a manageable side effect of the CAR T and bispecific antibodies, but it requires management in the hospital and a lot of support. Neurotoxicity is another side effect of these immunotherapies. One marker that we use, or a scale that we use, is called the Immune Effector Cell Associated Encephalopathy Score. Okay, just are you oriented to person, place? Do you know your name? Can you name objects? Can you count backwards? And neurotoxicity related to immunotherapies presents as confusion, trouble finding words, in extreme cases, seizures, feeling sleepy, drowsy, less responsive. If you undergo an immunotherapy, you're going to be asked to fill out a form every 12 hours. This is the form we use at our hospital. We're checking, are you oriented to person, year, month, city, hospital? Can you name 3 objects? Can you follow a simple command? Can you count backwards from 100? Can you write a statement? This sounds pretty easy for everybody here to complete now, but if you're in the hospital, you're sick, and you've had some of these therapies, some patients can't complete these simple tasks. This is an example of one patient who had a CAR T-cell, started out on day 4, wrote, "I love Shawnee." Day 5, the writing got worse. I was in the setting of neurotoxicity, couldn't write at day 5. Got treatment for the neurotoxicity steroids, and then by day 6, was able to write again. The handwriting assessment is critical for monitoring for neurotoxicity because sometimes what's called that, on the right, there's a column of mini mental status exam. That can look pretty good. People can continue to think, but the writing can be an early sign of neurotoxicity. And this is an example of a patient who underwent bispecific antibody treatment at our center, and he had some mild neurotoxicity on the 4th day there. He was unable to kind of write in the lines and had some what's called dysgraphia. We grade neurotoxicity just like we do for cytokine release syndrome. On the far right is a really extreme, severe cases where patients are having seizures. That's unusual. They're unresponsive. We can't do any of those tests on them. Most of the time it's mild confusion, sleepy, drowsy, and we're intervening early in the treatment of this condition. So if we compare across these immunotherapies, I mentioned there's 3 primary that are in clinic. We have antibody-drug conjugates, we have bispecific antibodies, and we have CAR T-cell therapies. I talked about 2 major toxicities of the bispecifics in CAR T, cytokine release syndrome, neurotoxicity. Those don't happen with the antibody-drug conjugates. The one that's available is belantamab. The efficacy, though, the trade-off there is that the efficacy for bispecifics and CAR Ts is higher than the antibody-drug conjugate that we currently have available. Maybe there will be better antibody-drug conjugates. And then also the bispecifics or the CAR Ts require an admission to the hospital. They require frequent dosing. Typically, they're only going to be given at transplant centers at this point. The advantage of the bispecific over the CAR T is that you can take that product off the shelf. You don't have to collect cells from a patient. So if you want to be considered for CAR T-cell therapy, we need to collect your cells. You have to have enough T cells to get to there. The bispecifics are able to be off the shelf and given. So which one do you choose? CARs, bispecifics, antibody-drug conjugates, they all target the same thing. In reality, it's a mix of, is the patient a good candidate for CAR T cells? Can they get through the toxicities? How is their disease controlled? Are they eligible for a clinical trial that we're studying these bispecifics or CAR Ts in? And sometimes the door will be open to you, sometimes it'll be shut. Sometimes you're pleading to get on a clinical trial and just don't meet the criteria. But all three of those options are active treatments in myeloma. So I talked about immunotherapies for myeloma. They're very active, but not without toxicity. But the toxicities, I hope, may have scared you a bit about the toxicities, but they are manageable. This antigen BCMA is one target, but there's others out there in clinical trials. Cytokine release and neurotoxicity happens when we target this antigen in myeloma. It'll happen with other targets on myeloma because of that T-cell stimulation. But we can treat it with these drugs, tocilizumab and steroids, to suppress the T-cell inflammation aspect. There's a lot of unanswered questions about timing, dose selection. My first slide said that maybe some of these immunotherapies are going to be moved up earlier. That's probably going to happen. Who's the best patient for CAR T cell? Who's the best patient for bispecific? What's the best target on the cells? We don't know those answers yet.